Welcome everybody out to episode 102 of Utah in the Weeds. My name is Tim Pickett, and I'm the host here, a podcast about Utah cannabis and cannabis culture and medical cannabis. And today, another discussion about psychedelics and these psychotropic medications. Ketamine is the topic mostly of our discussion today with Tom Swahn of Swahn Balanced Health. They have a clinic in northern Utah and specialize in major depression treatment with ketamine infusion therapy. This discussion goes right along the lines of our discussion with Steve Urquhart in a previous podcast where we talked about psilocybin and the Divine Assembly with Steve's church and those developing research and studies regarding all of this psychedelic medications that's coming down the pipeline. In fact, additionally, my discussion with the president of the Libertas Institute, Connor Boyack, about the psilocybin bill here in Utah that was recently passed, which developed a task force to study the effects of psilocybin and what the program would look like if, in fact, Utah was able to put a program for these psychedelics and this type of treatment therapy together. I'm excited to introduce you to Tom Swahn. He's a great guy and knows a lot about this therapy, has been doing this for quite a while. Just a really interesting new concept of treatment that you go to every couple of weeks, or you could go to a retreat and find these experiences and really get in touch with, what's happening deep inside the brain, changing perspectives and associating a different perspective to certain events. Has the potential to be really powerful for people, and I've known a lot of people who have had great success with this. Make sure you're subscribed on any podcast player that you have access to, Utah in the Weeds. You can also find us on YouTube at Discover Marijuana. We have a lot of videos there for cannabis and cannabis therapy. Keep doing this program with cannabis here in Utah, and just excited. It's a beautiful June day here. Welcome. The birds are singing outside. Enjoy this summer and this discussion with Tom Swahn. Where did this all start? Because it looks like you went to Westminster. Are you from here, Utah?
Yes, I've always lived in Utah, ranging from cities between Farmington is the furthest south, and right on the line between Ogden and North Ogden is the furthest north, but always in the little bubble.
You have slightly gauged ears. I don't even think they would have let you live in Farmington.
It's true that it was not well received there, and I've always been a little eccentric with my appearance, and so that was one of my first cues when I was young, growing up in an LDS family, that kind of free thinking and doing whatever you felt like wasn't well received. Made you a bad person, according to a lot of the church leaders in the neighborhood where I lived.
Right.
So from a young age, I was raised in an LDS family, but around 10 years old, I was telling my mom, I don't think God is real. I don't think these are good people here. I don't know why we would take our advice on how to be good people from people who are like this. And she would tell me, if you talk bad about God, you're going to get hit by lightning. And it's always just been super logical. And I was like, then why do I not get hit by lightning?
Right.
Seems, I just always needed evidence. And that's right. The thing about ketamine and other psychedelics is that the experience was a spiritual experience. And for me, that was evidence. I went from this staunch atheist to now I feel like a pretty spiritual person.
How did you get into medicine?
Frankly, it was just, I didn't really feel when I was younger like I had any sort of a calling, but I knew I really liked science. I wanted to do something where I could help people. So I was like, well, I'll go to medical school. So I started doing pre-med in college, and within a couple of years realized that's not something you can do on a whim. Sure, I felt like I could have the capability to do that, but without the drive to do it, that's so much work. So I was like, well, what can I do with like all the prereqs I've already done in pre-med. So I applied to nursing school, and they were like, yeah, you got all this prereq coursework done. You got great grades. Come on in. So I did that, and I just practiced as a nurse for a while. I worked in a variety of different areas, from like long-term care and hospice and physical therapy rehab, to I went to the operating room after that. And I left that. But
Where were you in the operating room?
At Davis Hospital.
Oh, cool. Yeah. That's what I did for 6.5 years, is GI surgery and trauma.
Oh, nice.
Right. For the general surgeons in West Valley. And the OR nurses there, you're way too young for that, right? That's where they go to retire.
Yes. Yeah. But I mean, there wasn't a whole ton of like critical nursing skills you needed. And so the fact that I was smart and could move like the wind, I was perfect there. I excelled at it.
Yeah.
You needed to have everything prepped and good and move fast.
Yep.
But that was one of the most fun areas to work. But yeah, it was not going anywhere for my career.
Right.
Kind of like watching my skills, slowly get lost.
Sure.
So I moved to the ICU. I wanted to do something else, but I didn't know what. And I went there to just get, all the skills that I could. And while I was there and watching people pretty much go through this like worst case scenario of almost dying, but then we pull them back from the brink just enough to survive, but their quality of life is garbage. And then we just send them home like we did a good job, and everybody pats themselves on the back. That was,
I know it is true, right? They leave home, they go home. They've just spent 10 days intubated, 27 days in the ICU. Then they, couple of 5-6 days on the floor, and then you just send them home.
Yeah.
And you're like, oh, this is cool. Way to go. I met a guy who, we operated on a guy who had he blew a hole in his small intestine just by running into a pole. He was playing some football and ran into a pole. And it took him, I saw him later, 6 months later, after he was discharged from the hospital, and he was skinny still because he had lost the weight in the hospital. And then he was decompensated so much that it's just so long to recover. And he was a normal, healthy guy, like before and after. You would have considered him after a really healthy guy, but it just so long to recover. And there's not a good support system, even still. You have to know how to navigate that aftercare system.
Yeah.
You feel like to get like the help you need, home physical therapy, home health. Like your insurance will pay for all this stuff, but I never ordered it. I'm a PA. I discharge people from the hospital. It wasn't my wheelhouse really. So I didn't really manage it.
I feel like each of these patients needs a social worker just to manage their own case, because our system is so fragmented that how do you keep track of all those things and work your way through it? And the insurance is the one that gets to call the shots at every turn.
Sure.
We have the people who stand to lose money if you actually get the care you need, deciding if you need the care.
Yeah, that's true. So when did you decide to go into NP school? And you went to Westminster, yeah?
Yes. When I was in the ICU and seeing us just send all these people home, and not even just like physically damaged, but mentally traumatized from the experience, we would just send them home and say good luck. So I was considering like doing CRNA, and that was based on my time in the OR, just because I thought it was a lot of fun. But I decided to nurse because I wanted to help prevent these issues landing people there. So that's why I decided to go to NP school. I also, I am a very ADD person. And so I figured if I got road, that would afford me the chance to switch specialty time I felt like I needed to keep it fresh.
Yeah. Describe nurse practitioner school. It's because the way we heard it this is not a slam to NPs, but I always think this is funny that I was told this is NP school, right? So I'm a PA, a physician assistant. In Utah, we are very, very similar. We used to be a little less similar until there was a bill passed 2 years ago that independentized PAs, right? Allowed us to be independent and actually bill people. And we're one of the only states that does that. But in school, I was told that nurse practitioner school is nurses teaching nurses how to be doctors. That's literally how it was described to me, right? Of course, this is a doctor who said it that way. Um, but what was it like for you?
I really had a good experience at Westminster. Um, through the clinical rotations, I was able to choose pretty much all of my preceptors. Like the school would provide them, but I had so many connections to doctors who I knew personally. So I just would cast a line out for different specialties and say, "Can I come follow you for a few months?" And so that was, it was beneficial for me. And a lot of my preceptors were MDs or PAs.
Sure.
And I guess there is, all of my instructors at the school were nurse practitioners as well. So that's literally true. It was nurses.
Yeah, right. Nurses teaching nurses how to be doctors. I mean, it's funny because your model, the nursing model, this like the lamplight of learning. My best friend in the world is a ICU nurse at IMC. Great guy, very, very smart guy. And there's some things about nursing that are really, really great. And then there's these other things that are their traditional nursing care model that is, I don't know, we don't talk about it a lot. Do they have that at Westminster? At the U, it was like the lamplight of learning or something. And in PA school, we have the same thing. We have these like things that were dumb. But does that taint you? Do you look back and think, oh yeah, that part I could do without, or I wanted a little more clinical diagnostic skills compared to the nursing skills, or alternatively, because you had all the ICU experience and all the nursing experience, it was a lot easier for you to move towards like, oh, that's the pathophysiology of why that was the way we cared for the patient in the ICU. Like now I understand how to diagnose that.
That was a lot more of my experience, was just I've seen these things done for years, and I knew already basically what we would do, but school was then taking it up the ladder to why are we doing these things. And so I do feel like that was a major benefit to have had so much clinical experience. But a little bit of the problem was everybody in my cohort had different backgrounds. And so depending on what you had seen in your clinical practice so far, certain subjects would be a breeze. And then like for me, I hadn't done anything with children, so I struggled with pediatrics a little bit. Mm-hmm. Almost to an embarrassing level, because like I have between me and my wife, she had 5 kids and I had 3 when we got married. So we've got 8 kids, but I'm still like looking at milestones. I can never like quite nail down like what age was that? Why are you looking at?
Yeah, that's when do you get hair there? Or you got to be way too early, right? Oh,
yeah. But yeah, I thought it was a pretty good education overall. I do feel like we took a lot of the diagnostic information and a lot of the other stuff that we learned from medical literature than just nursing.
Do you feel like there were things in that program that you right off the bat? Okay, so you're into ketamine and alternative therapy. You do some cannabis stuff, but did you feel like even through the program you were already a little skeptical, or did that come later?
Skeptical of ketamine?
No, skeptical of what we were taught. I don't know. I remember our pharmacology and our depression section. There are 5 medication types that we could give as first line, right? SSRIs, Wellbutrin. It does. And really it came down to one of the things they told us in school was just ask your patient if they know somebody who's taken a medication, what that medication was and did it work. Because if you diagnose depression in somebody and they know a friend who took Zoloft and they had success, they're actually more likely to have success with Zoloft than a different medication, just by the fact of knowing somebody who took it. Yeah. Which made my ears perk up like, what the are you talking about? There's like, you're like leaning into the placebo effect.
Yeah.
And some of these, that power of subjection is real. And so I started getting a little skeptical right from the beginning in certain aspects of medicine.
Yeah. In our covering of depression and stuff, there wasn't really anything like that they told us. It was actually broken down pretty thoroughly. And like, these ones are energizing antidepressants. These ones are more calming. In these cases, you want to use this. In these cases, you want to do this. But overall, we didn't hammer on that really all that much. Like, we did a basic amount of education and like some testing, but mostly it was just providing us tons of resources to reference once we were in practice.
Ah, nice.
So that was nice. But yeah, overall, like we didn't do any education on ketamine. That was something that I became personally interested in. I got really interested in it because it has this instant anti-suicidal effect, and I had a lot of suicide in my family growing up. I lost my dad to suicide when I was 8 years old. Lost my aunt a few years later, and there were like a variety of other family members who had attempted or succeeded in their suicide attempts. And this is something that could have changed my whole life. So I just became really interested in it personally, and the more people I talked to about it, I was finding this. Like, we all went through the DARE program as kids,
Yeah.
and like, if you use any of these illegal drugs, they're all scary, and you're going to trade like a moment of fun for your brain. You're literally destroy your brain just to have a fun time. So that was something I was like, yeah, I would never be interested in that. I value my intellect. But then we find out from the evidence, like, actually, these things are really good for your brain. Psychedelics, ketamine, they promote all this mental wellness, even in normal people without depression. So I became really interested once I saw that safety and efficacy data. And I found that the people I was talking to were consistently like, oh, but it makes you hallucinate. Like, I would never do that. I'm not that kind of person. And that was wild to me. I'm like, what does that even mean? What are you talking about? Like, not what kind of person? Like, the fact that it's a pleasant experience and good for you, to me, that's a win-win. But to them, there was something evil about a substance that makes you high, regardless of its effects.
Yeah, but so talk about your first, say a patient comes into you and I would imagine there's a lot of patients who come in to you now and they have never experienced anything like this in the past. They may have, like, even with cannabis, like, they may have smoked weed and gotten high and understand what that feeling is. But there are a lot of patients, I bet, that come in with nothing like that, especially in Utah. No experience of being quote unquote high. How do you explain ketamine to that person?
I've written like a whole ketamine preparation guide that I send out to them, tell them like a little bit about what to experience, how to get the treatment. But when they come in for their treatment, I tell them like, we could talk about this all day long, and you will still have 0% of an idea of what the experience you're about to have is actually like. Like, the only way to know is to go through it. And that's why, like, if you think about what language is, it's based on shared understandings. Like, you and I can use words because we both understand what that means. But if one of us has an experience that is completely outside of anything the other person could have possibly experienced, then there's no words for that. And so I tell them, like, it's going to be very bizarre. It's going to feel like an ineffable, strange journey that you're about to go on. But 95% of people feel incredible during it, just regardless. It strips away anxiety. It covers you in a blanket of serenity, and your body is totally safe and fine. We've got a good environment. I'm here for you if you need you. I'll be checking on you regularly. You've got a call light if you think. You're going to do great. But it is strange.
But just plain and simple, this is going to feel strange. Let it go. Right? Try to enjoy it, or just see where it takes you. How long are the, like, initial treatment? How long is the effect?
So the IV infusion itself is over 40 minutes that I do here. Usually about 10 to 15 minutes after that, the strongest effects are wearing off. But then there's residual effects for a few hours to the rest of the day, at least as far as like the physical effects. The mindset changes. People will usually experience a benefit right away. That first couple of days after, they suddenly are aware of joy again. It's kind of brought awareness to things in their life they can change, and it's given them a different perspective of their problems. But for that first treatment, it usually only lasts a couple of days, maybe up to a week or two at most. And that's why we start doing the repeat treatments in like a series. For most people, especially in more treatment resistant cases, they'll need a full series of 6 treatments done twice a week. And then after that, we usually are able to achieve a pretty robust and durable response. And I'll see most patients about once a month when their symptoms start to come back. They'll come in for a booster treatment.
About once a month. What's the duration, like the lifespan of a typical patient? Are they coming in for kind of a blast of treatment and therapy, and then you do once a month for, I don't know, do people do this for years and years?
Yeah, a lot of people, it's going to be like, basically, we know from depression, like your brain wants to build itself a certain way, and we can modify that with drugs. But as soon as you don't have the drugs, it's going to build itself back the only way now. And so usually it tends to be a long-term thing. But I have noticed, I've been doing this for a year, and I've noticed that my longer-term patients, I will start to see them less and less over time. And
Yeah.
at first, I worried that was just they couldn't afford it or were just dealing with it. But like when I do see them again, they're, oh, I've just been doing great.
Do you I don't really know a lot of the research behind this, but is there a rebuilding of neural connections in the brain, like with psilocybin? The fungus, that is affecting something in the brain where you're creating new neural connections, or you're disassociating some and then allowing others to, I don't know, to develop, or you're finding new connections. Because in PTSD, right, you have this emotional part of your brain that's connected to the logical part, and that builds these calluses where it's just firing over the same thing. So people get in the thought loop. Every time they go to a certain experience, they experience that trauma again, where psilocybin is starting to show that these things are changing those neural connections. Is that the same with ketamine?
Yeah, it's a lot of the same stuff. With the classical hallucinogens like psilocybin or LSD or ayahuasca, those are all serotonergic in nature. They work through this one is an NMDA receptor, it works with glutamate, and that's like our brain's main excitatory neurotransmitter. And so you get a different feeling with the experience. Psilocybin and other of the classical hallucinogens can be very emotional. They're very like mood augmenting. And so whatever you're experiencing is just like an amplified version of that. But ketamine works through, they call it a use dependent blockade. So as soon as like those neurons are trying to fire, the most active ones, where those thick neural tracks of those ruminating negative thoughts are, those neurons will start to get plugged up with ketamine. And so a lot of patients will, during their experience, try to be telling me what they're experiencing, and then suddenly be like, lost my thought. And I'm like, yeah, we know that's what's supposed to happen.
Right.
But it interrupts those by blocking them with ketamine, the most used neurons. But at the same time, it has a blockade effect on inhibitory neurons that keep our subconscious quiet so we can think. And so it's similar to psilocybin. We get widespread brain communication through these back channels, areas that don't normally communicate. They've been able to identify a cascade of effects that results in an increase in brain-derived neurotrophic factor, or they call it BDNF. And that actually does increase dendritic branching and synaptogenesis. People will have new neural connections forming at an increased rate.
Wow. From a illegal standpoint too, obviously you can't, I mean, your clinic can't do psilocybin treatments. Right? Not, what did you say? Not yet?
I said not yet, but one day. They did pass through the Utah legislature. Is totally done, signed by the governor. House Bill 167 is, I think it's called the Psychotherapy Mental Illness Task Force. something along
Yes.
those lines. And so, where they put together this task force to make recommendations for currently illicit stuff like psilocybin or MDMA, and make recommendations on if and how much and who can use these for their therapeutic benefits. And I think that it's good news that we've identified these things definitely are helpful. It's to a point we can't really deny it anymore. So how do we use them? And so
Sure.
I'm hoping that their report is due by the end of this October. I'm hoping that we'll get some progress, and at that point, maybe we'll change the clinic to Swahn psychedelics and offer more things.
Nice. Is there a difference between, you mentioned psilocybin, MDMA, ketamine, ayahuasca? Is ketamine closer to MDMA than psilocybin, or is there known differences?
Well, so MDMA is itself in an interesting middle ground. People will argue whether it's a psychedelic or an empathogenic or an entheogenic, which I mean, it depends on how you're interpreting it. Like psychedelic just means mind manifesting. And so it's these mind expanding drugs, I think, could encompass all of those. But entheogens are like God manifesting, or it's a class of these drugs that just increase feelings of love and social connection. And MDMA technically is methylene dioxymethamphetamine. It's a form of methamphetamine that's tweaked in a way that makes it both less harmful but slightly psychedelic. And they're using that specifically in people with PTSD because it promotes self love and forgiveness and connection to other people in a way that helps people stop feeling like they're worthless, or these traumas were their fault, or that it needs to control their lives. As far as the classical hallucinogens and ketamine, they work through a much different mechanism. Mostly they're considered psychedelics together because of the experience ketamine creates is, a very intense psychedelic type trip, just like the other ones. But whereas some of those I think will be better ultimately for depression because they, bring that freshness and joy back to life. I think ketamine, with its ability to ease anxiety and feelings of fear or shame or guilt, I think that that's ultimately a better tool to face some of these traumatic memories. Although they are finding with psilocybin studies, the benefits in some cases have lasted up to 6 months, a year. So I think that that will be a better option in a lot of cases.
Yeah, it will be really nice to that point to have multiple options, right?
Yeah.
Because right now we have, well, I mean, it's nice to have just the options we have, frankly, but it will certainly be better when there's more options. And they're already out there. MDMA, psilocybin, ketamine, cannabis, even ayahuasca, peyote. They're out there. They've been used for centuries, but
Yeah.
we just don't have them in traditional medicine because we need the pharmaceutical companies to sign off on these things. Unfortunately, the way our system works.
One of the things I think will be really beneficial going to the future as we get more data on all these things, on their safety and their effects, will be to be able to combine them in ways that will amplify effects. Like, I mean, if you read some of these, like, what do they call them? Trip reports online. Like, people talk about mixing ketamine and MDMA, or like psilocybin and ketamine, or whatever, cannabis and these other substances, and the synergistic effects could, I think, provide invaluable things that none of them could do alone. But we'll have to wait until we have more safety data.
Right. Yeah,
Other,
how to blend them together, and then, boy, you're going to have to be monitored. Speaking of monitoring and ketamine, so you've got a twice a week therapy. You can come downtown and you can, get this therapy, or go to Clinton and get this therapy. But what about going to retreats? Is there a place where ketamine therapy can be done in like a retreat setting where you go somewhere and because for me, it seems like Memorial Day weekend would be a perfect time to where
yeah.
to where I could show up Saturday morning, I could meet the provider, I could have a little lunch, I could get a little intro to the system, then I could have my first ketamine session, that day, see how that feels, do another one Sunday, cleanse on Monday, come home, or a 6-day.
Yeah.
How does that work? Or do these things, you can't do them like day after day?
So, I mean, ketamine, there are plenty of studies that have shown, like, have done consecutive day treatment, or even you can find some that were like a 72-hour continuous infusion done in the hospital. And that sounds crazy because it has a time dilation effect. It would feel like you were there for 3 infinities. But
oh wow! So when you're in the K hole, right? Is that what we call it? I use ketamine in the emergency department for like the kid has, the kid's cut his tongue open, and I've got to sew up his tongue, so we're going to use ketamine. We use ketamine for that. What, I guess, off topic here, what's the dosage difference in what I'm using in the ER to put a person down so that I can do a procedure versus what you're using in clinic?
So I think the IM dosing for sedation was like 6 to 13 milligrams per kilogram, something like that. At the clinic here, I give it from 0.5 to 2 milligrams per kilogram. Because with the dosing of ketamine, there's actually like an increase in neural activity up to a certain point. And then that ketamine blockade of the neurons shifts from like blocking certain channels while they're open but just blocked to totally shutting them down. And that's when we get that like total anesthesia sedation. But usually they'll, like, for sedation, they'll mix it with benzos or
Sure.
whatever else to promote amnesia of the experience and to give a little more sedation. The funny thing about kids is they still have like a layer of magical thinking. So whereas adults will get the emergence delirium when they have like super heavy doses, and that's why they stop using it as much for anesthesia.
Yeah.
Just fine with that. They go on these magical journeys and they're cool with it.
Yeah, we use it more in kids than we do in adults for that
Yeah.
for that exact reason, right? The adults tend to not have those heavy doses, can tend to have like little mini nightmares. And then then not only are you dealing with the injury that you have to fix, but you're dealing with a human being, a grown up human being who's like not having a good time at all. But these doses that you're giving are much, much lower.
Yeah, they're much lower, and 2 milligrams per kilogram gives us a healthy buffer before we would reach any sort of sedation when given over 40 minutes. And even with that dose, the experience is quite intense. I don't get most patients like anywhere near that dose.
I see. Do you build up a tolerance like you do with cannabis and THC?
It's not real clear at this point in the literature. What I've seen here at the clinic is that people will start to build up like a more of a tolerance to the negative effects before they do the positive effects, similar to cannabis. And I don't really think that there is that much tolerance. Either that, or it must build quickly and maybe wear off quickly. By the time we get done with the induction series, we'll get like a month out and do a dose of the same one, and people will report that it feels stronger. So that could be potentially a mild tolerance that was built, or frankly, I kind of think it's just you had that gap between the series of these intense experiences, and then after you take them a little more intense than you remember.
Yeah, and you're also used to, I could see getting used to, not that you're building up a tolerance, just getting used to the effects and getting used to that journey, where the mind goes, and being okay with like, we can do that just a little more intensely because now I'm used to it. Whereas same thing with cannabis, right? You use your first time, maybe that causes some anxiety if you use too much, but then after you get used to it and you understand the sensation, that intensity level, then you seek that out in a lot of ways, right? That's your therapeutic dose.
Yeah, I usually will describe it to my patients like a dog getting used to riding in a car. Like at first, the time it might be this flying metal death box because they have no idea what's happening.
Sure.
But you stick your head out the window on the freeway on your little space cruise.
Right. And then now all of a sudden you really want to get in the car all the time. Yeah.
Yeah.
Huh. That's a good way to put it, because you're right. You wouldn't understand. It's a really good analogy.
Yeah.
What else? So have you worked in a place where you're doing daily sessions, like a retreat setting?
I haven't. I've done daily consecutive sessions for just a few patients, like if they came from out of state or something like that, where it's not practical for them to stay and do twice a week for 3 weeks in a row. So in those cases, I've done like 3 treatments in a row, and like the first time they do great. Second day, they're like, "Oh, I still feel a little overwhelmed from my first," and then by day 3, they're like, got a little bit of a hangover, and I don't know if I can do this hero's journey for 3 days in a row, because
Yeah.
it truly, like, some of the experiences, especially if we're going up in dose, can feel like you literally spent a lifetime on this journey.
Wow. Does ketamine therapy work in conjunction with behavioral therapy really well? Is that
Yeah,
part of the decompression of all of these things that are coming up for your patients?
yeah. The optimal way to do it would be to have a therapist, discuss with them that you're going to do ketamine therapy, go over some grounding techniques, some intention setting to decide what you want to get out of the therapy. And then when you come in, that can kind of act as your GPS for where your experience goes. But then once they start, like you said earlier, the best thing and really the only thing you can do is let go and float downstream. Just go with the experience, fully surrender to it. And I'll coach my patients like you might have emotional content or even like traumatic memories come up. But if you trust the ketamine, trust yourself, trust the experience here, lean into it, then you will be able to get a different perspective and process these things in a way that might have been impossible for you. And so after they go through those experiences, I usually recommend try to get into your therapist again in the next couple of days while we have that increased period of synaptogenesis, of that new neural connections happening at an increased rate. And that way they can really capitalize on the fact that they've been knocked out of their rut, their ruminative thoughts, as well as this opportunity to develop new skills faster.
Yeah, I can just see how that would be really helpful for people who go through this experience and then want to talk about what it means and how it can affect them and what to do next. And um, that change in perspective for PTSD, but we know that being able to see the event from a different perspective essentially it's one of the key pieces to curing, if you could cure PTSD.
Yeah.
Death. Do you have people that come in and do ketamine treatments who are dealing with cancer diagnoses and like facing their own death or the death of a loved one?
That's something that is a really useful aspect of ketamine therapy or other psychedelics. I personally have many of those patients. I actually know people in my personal life dealing with cancer and am unable for them to come in.
Yeah.
But it's one of those things that, like, frankly, it makes you feel connected to the way that it makes it seem like you won't be gone if you die. You just will return to the ocean that is the universe we're all swimming in.
Yeah. What what are those barriers? Like, how do we get past that? How do we get past people's resistance to therapy like this? We've been trying. I've been trying with cannabis. It's
Yeah,
easier. I almost think it's easier with cannabis than it is with ketamine.
it certainly is. And I'm
Yeah.
a QMP as well, as you know. I can far more readily convince people to try cannabis than ketamine. It still has a scary aspect to the journey because you tell people like it's life changing,
Yeah.
but it's super intense, strange, and um, especially the people I've known who are going through uh, chemotherapy and cancer and the dying process, um, they seem to be kind of stuck in that fear, and they're I guess just afraid of what they'll experience. It seems like if you tell them this will make it not seem scary that you're dying, or at least
Yeah.
will help change your perspective on it, I think that just in the moment sounds extra terrifying.
Yeah.
I'm not I'm not sure how to really go about that, but it is something I think about pretty
I mean, it seems
frequently.
like society is moving it forward slowly, but I talked to Connor Boyack, he's the president of the Libertas Institute, was really influential in getting the cannabis law passed. And he was influential in the psilocybin bill, the task force that was
Yeah,
passed this session. And we talked about how, generationally things will change, and we'll probably get to a point where ketamine is much more normalized, where cannabis is much more normalized throughout the population. But on the other hand, the person who needs it tomorrow, right? That 62-year-old with major depression who needs a ketamine treatment, like to save their life, to your point about your family, we can't really
yeah,
afford to wait to let society catch up. We really have an obligation, I feel like, as providers, especially to educate people that there's something else out there in order to push
yeah,
that conversation when that 62-year-old needs it tomorrow, or else they die on Friday, right? We need to figure out a way to get that
yeah,
conversation like speeded up.
yeah. And it's something that I ultimately I feel like we should even be doing when patients come. But the problem with giving it in that instance is that there's a horrible
Yeah,
environment to do it. You're in there, though everything's sterile and people screaming up and down the hallway. Like that's a recipe for a bad experience. So I don't know what the ultimate infrastructure would look like, but I do feel like we need to take this seriously and consider how do we
right.
implement this.
Yeah,
Even the ultimately for depression are kind of baffling to me. We're still on this sort of in this position that ketamine's new. It should only be used as a last resort. And like why do we reserve these therapies that I feel like could stand to improve almost anyone's quality of life and experience like this, and we reserve it for people who are already at rock bottom, and everybody else is just expected to deal with whatever
yeah.
they're dealing with.
That's surprising to me too. Why is this last line therapy instead of like first or second line therapy? Why can't we change the mentality
Yeah,
of prescribing 2 or 3 pills to, okay, maybe, which do you want? Here are the 3 options. We can do a prescription medication, and you can try that for a month, and that's totally okay. We can give that a shot. Maybe you'll feel more comfortable with that in the beginning. We also have this treatment protocol with ketamine therapy. Both are in conjunction with behavioral therapy, and you can kind of
hmm,
decide that here's the evidence on both sides. Let the patient be part of the conversation. I mean, I know the answer is probably just, well, I have 15 minutes with the patient. The easiest thing to do instead of explain this whole thing to them is just to write a prescription and see them in 3 weeks. Just be done. Oh,
yeah,
besides that, your
it,
Swahn, they don't take insurance, right?
yeah,
Sorry,
exactly.
but the pill totally covered, no problem.
Yeah, and then that gets us to kind of the frankly the bullshit around esketamine of like, oh, it's this. We just filtered out the left-handed molecules from ketamine, called it a new medication. Now it's $800 a dose instead of like $3, and you still need 2 hours of monitoring, but we've got a patent on it, so we can charge whatever we
Yeah,
want.
what
Like
what is up
it's
with
a
that?
case where we've let the pharmaceutical company decide like this is how we make money, so this is how it needs to be done, rather than using these tools we have and know are effective. It's considered off label and came off patent in 1990. So nobody's interested in trying to push it for FDA approval because they can't make any money back.
Do you use nasal ketamine at all?
I don't hear clinic, but you can get racemic ketamine, which is just the 50-50 mixture for people that don't know. You can get that just compounded in a nasal spray. Like I could easily prescribe that to a patient, and there's no clear evidence whether S-ketamine or the right-handed molecule R-ketamine are any more effective. Like I'm sure they have minor differences in psychoactive effects and duration and whatever, but when we already know one form is very useful just in its super cheap form, like it seems strange to me that we would allow our insurance companies to only cover the super expensive form that's not proven
Wow.
to be any better.
So how do patients get in touch with you and get associated with this type of therapy if they have major depression or if they want to explore it and just come talk to you? Like what's the process?
Yeah. So what I usually do is just have patients, there's a self-scheduler on our website. Our website is SWANbalancedHealth.com. Swahn is SWAHN, and then balanced with a D, health.com. They can schedule an appointment right on there. They can give us a call, 801-613-8842. And I'm happy to answer calls when I can, anytime. They can even text that number, and we can do a phone consultation. There's very few contraindications to ketamine therapy that would make it unsafe. Some of them are like unstable hypertension, more severe cases of cardiac, kidney, or liver disease, active psychosis, elevated pressure in the brain or eyes. We proceed with caution in cases where there's substance abuse issues. But outside of that, like there's very few reasons that it's contraindicated. So people can even schedule online themselves. As soon as they do that, I will send out intake paperwork, and then they'll fill that out. They'll meet for a first appointment and go over everything, make sure that they are an appropriate candidate, and then we can get started right.
And how long does it usually take to get in?
I mean, right now the clinic's still young. I've been doing this for a year total, but we moved into this location October 1st, 2021. And so we've only been here 7 months.
So still building up a patient base, still plenty of availability is essentially what you're saying.
Yeah, I should have openings pretty much every day that we're open. It's pretty rare that the entire day is fully booked out, so people can get in right away.
Do you guys, and then you do this, you do cannabis, and what else does the clinic do? Those are the two things, right?
That's all I do. Yeah, basically when I started offering ketamine therapy, the improvement in people's quality of life was phenomenal. Like I've never seen anything promising in medicine. And so I wanted to build a place that went away from the sterile clinical feel. And so this clinic that we've opened here, I've got different themes for each patient room. Each of them has a different nature-based theme. So like I've got a forest room with tapestries and like different plant stuff. There's an Echo Dot in every room to play music. There's 2 recliners so they can bring a guest. And I've got light projectors that actually will reduce a lot of the dizziness some people can feel from
cool
visual effects. So they can wear an eye mask if they want, but the projectors have done a really good job of changing it from like these kaleidoscopic visuals to more of just like a flow. It feels very incredible. But I wanted to feel more like the spiritual experience that I feel like it is. And like you said, with these retreat settings, I think ultimately that'll be a beautiful option. And ketamine was known as the buddy drug when it was first being used. It made its debut in 1970 in the Vietnam War. And they called it the buddy drug because anybody could grab a syringe and sedate your buddy. It was just that safe. It preserves cardiovascular function. It preserves respiratory function and protective reflexes. So there's no life support needed. Even in here in the clinic, I feel like checking vital signs at all is more of a medical formality than anything. Like there's rarely anybody with any issues. And usually it's if they've stopped taking their blood pressure medication or something that we'll even see a problem.
Sure.
not have to like postpone treatment until their blood pressure's under control. But in general, yeah, if you were able to establish with a bunch of people at a retreat that they had a good health history, were good candidates, their vitals were stable, I don't even think you would need to check them again for the rest of the weekend. Granted, that's, I guess, sort of a
talking from experience, right? You're comfortable with it. You know what to expect. You know what to look for, which is awesome. This is awesome. Have we missed anything that you want to talk about?
In general, no. I think that covers most of it. I mean, there's a lot of specifics, and I spend all day talking about this. I'm very passionate. So people are welcome to ask me any personal questions about their case or what to expect. But yeah, I mean, I think that's a good overview.
This is good. I want to hear. I think we should get back together down the road and talk about how the clinic is going, and also talk about like especially with psychedelics, as we expand like the access to other psychedelics, and we talk more about more psychedelics than just ketamine. I mean, I'm interested because you're in this field, you're a subject matter expert. So I think this will be an interesting conversation to have again. I appreciate you coming on. SwannBalancedHealth.com, right? You're in Clinton.
In Clinton, yep. Clinton, Utah.
SwannBalancedHealth.com. Thomas Swahn. Thanks, man. Thanks for coming on.
Yeah, absolutely. Thanks, Tim. It was a pleasure.
Yeah. All right, everybody. Stay safe out there.